And with that, I will now turn over the speaker to Dr. Broyles. Mike is the Director of Clinical Pharmacy Services at Five Rivers Medical Center. 35 years with experience in pharmacy, teaching clinical programs implementation. His major interest has always been appropriate antibiotic utilization. He's written and presented very extensively on sepsis and more recently on procalcitonin's role in sepsis. So let's welcome Dr. Broyles.
Thank you all. Thanks for the opportunity to share a pharmacist's perspective on procalcitonin use. So disclosures, as far as that goes, consulting, I do have some consulting arrangements with Thermo Fisher. I participated in advisory boards for Roche and for Thermo Fisher. Historically, I've worked with a lot of different organizations. I spent many years with a large IDN and was over clinical initiatives for those for that large hospital group, and so I had a lot of different projects along that line. The information I give today is based on my clinical experience and my interpretation of the literature. So objectives, I would like to kind of just break it down very simply. We've talked about the biomarkers that are out there, and I would really like to differentiate PCT from the other biomarkers and why it's important from the perspective of managing your patients and as far as severity of infection, and also from the standpoint of antibiotic use. So we're going to kind of go along that line is, why use PCT, at least from the perspective of antibiotic management. And then, so we want to kind of get into that and then spend just a little bit of time in a couple of cases. Very importantly, I'm going to discuss how we use PCT in our facility and the importance of serial measurement of PCT and their values. So typically, when you talk about PCT, a lot of times it kind of falls into two bins or bundles somewhat. And that is that of severity assessment, as far as, particularly the initial severity assessment. And then there's kind of that second piece that you get into, which is evaluation of your therapy. Okay, so that's the kind of the approach we're going to take. So if you look at what we want from a biomarker, what are we looking for? What's the ideal biomarker going to give us? And so one thing is we want it to be sensitive for bacteria, i.e. we want it to always rise in the presence of bacteria, and we want it to be specific. We don't want it to be elevated in the presence of a virus or a fungus or a parasite. We would like it to be very specific for bacteria. And then the other thing is that if you think about it, we don't really want it to be affected by a patient's immune status or the use of immunoactive drugs or steroids and those type of things. And then the last thing is it has to have useful kinetics, meaning that it has to rise promptly, it has to have a favorable half-life, and then it provides us with a lot of useful information. But what that causes is a problem for us. We've studied more than 175 biomarkers to date, and there's only one biomarker that really provides us with that information that we're looking for. And the problem is, as Dr. Gluck spoke to, is that the body's response, that inflammatory response that takes place, whether it's from bacteria or non-bacteria, whether it's acute or chronic, essentially it looks the same. And if you look at all the biomarkers that we use, we look at interleukin-1, interleukin-6, tumor necrosis factor, all those are inflammatory mediators. And so they don't really help us from the differentiation standpoint. We need to be able to differentiate. The other thing is that they don't always rise. I'll talk a little bit about that when we talk about the white count. Essentially, if you're looking at the white count, if you go to the literature and you're talking about sensitivity, anybody got any idea what numbers are out there in the literature as far as sensitivity to bacteria? It's less than 50%. It's not as high as we think it is, at least if that's what the literature would suggest to us. The other thing is that all of those, because we're studying inflammatory markers, the patient's immune response does make a difference because you're not going to have the same production of those inflammatory mediators. And so then you throw on top of that those patients with autoimmune diseases. And how many times do we use steroids in the treatment of our patients? Fairly often, right? And obviously those will affect the response of those markers also. So if we look at the markers that we typically use, the white count, CRP, we look at lactate, and we compare and contrast that to procalcitonin, we can see that the specificity, the sensitivity, there's a huge difference, okay? And if you think about it, the white count, the thing that we look at so much, and we always say, well, the left shift, there's the left shift. But if it only rises less than half the time, and if it's greatly affected by inflammatory responses, that kind of diminishes our usefulness to us, although it has very favorable kinetics. Additionally, there's 596 drugs and or diseases that affect the white count, either up or down. And if you stop and think about it, this is just a classic example. If you look at corticosteroid use in white count, there are 4 things that cause the white count to become elevated when you use corticosteroids. Generally happens in the first 24 hours. One is that you have release of the white cell from the endothelial lining. Number 2 is you have a delayed apoptosis, delayed cell death. Number 3 is the white cells don't penetrate into tissues as much as they did. And then the 4th thing is that we actually have an increased production of bands. We have those immature bands that are produced in the presence of steroids. And so if we're thinking of this white count, today it's 12,000, tomorrow it's 24,000. They've been on Solumedrol, 40Q6, and you're evaluating that patient, what are you thinking? And so in theory, that band response is not going to be as high as if they had a bacterial infection, but still when that band number goes up, you're still thinking to yourself, well, am I really headed in the right direction? And C-reactive protein is not a lot different. It's actually slightly more sensitive for bacteria than the white count is, but it still is that inflammatory process. The big thing with CRP is it has no correlation with severity of illness, and its time to peak is usually about 48 hours. So quite a bit of difference there as far as it's being useful. Lactate, on the other hand, and I'm very glad that Dr. Gluck said this, this is the thing that just drives me nuts. I was at a meeting for a buying group. And so you have, in this buying group, you have lab directors at a corporate level, all gathered in this room, and we were discussing procalcitonin, and we were talking about lactate. And they said, it was beyond my imagination. They said, why do we need PCT? We have lactate. So that was very clear misunderstanding of what the purpose of lactate is and what the purpose of procalcitonin is. Lactate is a marker of perfusion, but it can also be elevated in CHF. It can be elevated in other conditions like acute MI. And so the key is that we don't want lactate to be what we think PCT should be. And in their mind, they were looking for a simple out. There's not the education process. You don't have to bring in the instrument. You don't have to do all those things. It's very important to keep lactate in its place. Still a very useful marker, but we need to keep it in its place. Procalcitonin, on the other hand, the huge thing about this, and we've seen this before, but what I want to point out is the sensitivity and specificity, which is very important. But if you look on the X graph, and you look at lactate and you look at CRP, see how quickly they veer off? So they have a very low sensitivity for bacteria, and that's one of the keys, is that it just doesn't really help us that much in bacterial use as far as managing antibiotics. So if you think about those things that we really wanted out of the ideal biomarker, okay, what is it that we wanted? We wanted it to be specific and sensitive. And if you think about PCT, its induction and release is in direct proportion to a bacterial insult or load. And that's huge. If you think about it, we don't get that from any of the other biomarkers that we have out there. So at this point in time, I know what the body's response is to that bacterial load. So if I have 0.05, I know there's no response. Okay, if I have a 10, I have a relative amount of bacterial load to the body that I can look at. The nice thing that is that 24 hours later, I can look at that change in PCT, and it can tell me, did my bacterial load or burden go up, or did it go down? And that can help me assess my antimicrobial therapy. So PCT is an indirect marker of the body's systemic response to the bacterial load, and that's huge. That's the only one we have out there that's been able to help us like that. So that then is those serial measurements, looking at those changes over time. They're so important. So this is the important part about the kinetics. Rises in that first 3 to 6 hours. Fortunately for us, has a half-life of about 24 hours. So just like you do in drug therapy, Essentially, if you had 10, a value of 10, 24 hours later, it would be 5, 24 hours later, 2.5, 24 hours later, 1.25. So very useful kinetics that's very helpful. The other thing is that it's very important when we're using PCT that we don't start repeating procalcitonin values early on because it'll mislead us. And what I mean by that is this. Whenever they first started using PCT, one of the things they did is they gave a 4 nanogram per kilogram injection of endotoxin to your test subjects. And they measured the response of PCT. And that's how they got that 24-hour curve, where you see that peak around 24 hours. Now, the cool thing about this is that there was no bacteria present. So even without bacteria being present, your body was still mounting that immune response, that PCT release, over 24 hours. Okay, so it's useful to think in terms of that to help understand the kinetics of PCT. And then appropriate therapy, generally, if you have appropriate therapy, you would generally see a trend down at the end of that 24 hours. At least it can be the same or slightly higher. So that's useful, but then when you have the big rise, then it's a cause for concern. We'll talk a little bit more about that. So the process at our hospital. If you prescribe an antibiotic at our hospital for treatment of infection, now not surgical prophylaxis, if you prescribe an antibiotic at our hospital, you get a baseline PCT. I want the assessment of bacterial load at a point in time, and then you're going to get a serial measurement. You're going to get it about every 24 hours for 4 doses or for 3 days, and it's built into our order sets that way. So from the ED to the floor in the electronic chart, all of those infectious disease type diagnoses, we have those built in. So if you have CAP, you have aspiration, you have UTIs, you have Kylo, whatever it is you have, PCT's checked for baseline, and then you're going to get one every 24 hours, and then you can modify that if you want to, but they're pre-checked boxes. Pharmacy will look at every PCT value, and we'll confer with the physician if it gets missed or if there's a problem. So somebody has to assume ownership. You guys as physicians, you see a group of patients, and you have pharmacy sees everything. And so we undertook the process of making sure that all the PCT values were evaluated and that everything was acted on. And so let me give you a couple of cases here. JB, 75-year-old female, and this is a comparison of 2 presentations to the hospital. She came in with the same diagnosis, same chief complaint, about 9 months apart. So this is the same person. So this is about as close as you can get to looking at comorbidities. So chief complaint, dysuria, fever, nausea, and vomiting, and as you go back and forth across, the temp was about the same, respiratory rate, very similar. Blood pressure, she was normal tensive, heart rate 95 versus 91. White count, 28.4. In their second admission, 26.4. Lactate was normal, both cases. Serum creatinine, 1.6 and 1.8. So on the Medicast, she was nitrite positive both times, leukocyte esterase positive, 4+ bacteria. Okay? So upon admission, on the first time, this is the JB1, her PCT was 2.9. Okay? Now she was placed on ceftriaxone a gram through 24 hours. Okay, that was her first admission. Now her second admission, her PCT was 1.9, but she was placed on levofloxacin 500 Q24. All right? So here we have the first day, and you can see that in the red, that is the levofloxacin, the second admission, and in the blue, the 2.9. Okay, so the next day, almost 24 hours later, we see a dramatic change in PCT. Okay, so what does this tell us? Well, let's look in the blue, JB1. Okay, she went from 2.9 to 1.7. She's on ceftriaxone a gram Q24. Looking at this patient, what do I know right now? Yeah, she's on appropriate therapy, right? So this response is favorable. 40 to 50% reduction is an ideal response from PCT. I also know that, so she's on ceftriaxone, so she's probably going to be sensitive to a 3rd-generation cephalosporin. At least I know that until I have a culture and sensitivity report back. Now, in the second case, we went from 1.9 to 10.2. What do I know? Almost 24 hours. Is my antibiotic effectively treating that patient? No. Okay. Now, without PCT, what is going to happen when I continue this patient's therapy? Because I have nothing else to go on. I mean, her white count may continue to go up, but typically what's going to happen when we don't change therapy and the infection progresses? She's going to end up in sepsis and so on and so forth, right? Now, in this case, the nice thing was, at this point in time, her cardiovascular status was stable, okay? And so in this place, the levofloxacin was replaced with meropenem, okay? Now, we don't always do this, but in this time we did. We repeated that PCT in 12 hours because if that therapy is effective, we will already begin to see a trend down in the PCT. Now, the reason that was done is this lady had a long history of urinary tract infections, and she had had multiple organisms in her history that might not have been covered by, or that had been difficult to treat. She'd actually had a VRE infection one time, so she wasn't on anything to actually cover VRE. So anyway, it was possible that she could have had something resistant. I mean, meropenem is going to cover most of those things, but she didn't have any gram-positive coverage. So repeated in 12 hours, and you can see it dropped to 8.6. So she went from 10.2 to 8.6. So when I went home that night, what did I know? This patient was on effective therapy to actually treat her infection. And then as the days progress, you can see that trend where you see that favorable reduction in PCT. Okay? Now, much like Dr. Gluck, we will stop therapy except in endocarditis, osteomyelitis, and skin structure infections. When we get that 80% reduction, or we get to a 0.5 to 0.25, we stop therapy. In the last case, the first case, she actually was stopped on day 4. She went home on no antibiotics. And then on the second case, where she was at 1.9, we would actually extrapolate that out. So I know that if it's, say, 2 today, tomorrow will be 1, then it'll be 0.5. She only got a few more days of antibiotics when she went home. JW is a little different story. He's a 56-year-old male construction worker admitted with symptoms of pneumonia. So he had had asthma since childhood, 1.5 pack per day smoker, chief complaint, shortness of breath, productive cough, malaise, and fever. This had been going on for almost 2 weeks. He had got the obligatory Z-Pack that everybody in our institution or comes in seems to have failed the Z-Pack and they show up. I know you can probably never ever use a Z-Pack in your area. And so medication-wise, not too much going on. You'll notice that he's on just a touch of prednisone for his asthma. He had a history of COPD. And so he presents with a temp of 99.8, normotensive 145/86, and pulse of 90. Respiratory rate 20, pulse oxygen is 92% on room air, with a white count of 14.7, 6 bands, normal lactate. So chest film, auscultation, right middle, and lower lobe pneumonia was the diagnosis. So the plan was to just stop azithromycin, put him on levofloxacin 750 daily. Okay, now let me ask you a question. If I told you his PCT was 0.7, okay, does that give you some idea about his severity of illness? And would you agree that levofloxacin would be an okay choice for him, for a community-acquired pneumonia patient? Okay, so I'll tell you in our facility that if you look at strep pneumo, Haemophilus influenza, you look at any of the common pathogens plus the atypicals, we run 99% with levofloxacin. It meets the guidelines for COPD exacerbations. And so, would you be okay with that? And I would say I probably would be. Now, let me ask you this question. If I told you his PCT was 15, do you feel any differently about this patient than when I told you it was 0.7? Yeah, you do. Why do you feel differently about it? You know that there's a greater bacterial load, a much greater severity of illness that's brewing underneath. So would you be likely to reassess your therapy plan based on a PCT of 15? I would say that you might, okay? So here's how this plays out. His initial PCT was 0.7, okay? So 0.7 is our initial. The next day, almost 22 hours later, he presents with a slightly higher temp, 101.8. His blood pressure is still stable. Respiratory rate's up to 22. His white count is now up to 22.4, 10% bands. His lactate's 2.1. Clinically, he's unchanged, okay? Now, lab-wise, slightly worse. Clinically, essentially the same. How do you feel about this patient? Do you have any different impression about the severity of his illness based on this initial clinical exam? Probably not a whole lot, right? But what I didn't tell you is that his procalcitonin is 36. Okay? Now, Do you feel differently about this patient than you did before? Yeah, you definitely do, or I did. And what's interesting about this is that this was when we first started using procalcitonin. And the physician that was in charge of this patient didn't believe in that blankety blank test. There just needed to be additional time for the antibiotics to work. Okay, that was the quote. I can tell you at the end of almost 24 hours, if your PCT goes from 0.7 to 36, that antibiotic will never work. Okay, all right. So the next day, here's what happens. Temp is 103.6. Blood pressure dropped to 106 over 52. Respiratory rate of 26. White count's 28.8. 12% bands. Lactate's 5.6, and his PCT is 86. Okay. We got his blood gases, and obviously you know where this is heading. He was in sepsis. He was placed on the ventilator. The Levaquin was stopped. He was started on vancomycin and meropenem. And our sputum, our gram stain had coagulase positive, gram-positive cocci clusters. So you're kind of thinking this is an MRSA, potentially. First blood culture was the same, and his nasal screening plate was positive for MRSA. So by the end of day 2, his PCT had dropped from 86 down to 72. The next day, his white count dropped to his temp was 101, blood pressure was normal. White count dropped to 23 with 10% bands. PCT, most importantly, was 46. Okay, there was 2 blood cultures, both were positive for MRSA, and his sputum, of course, could be colonization. We don't know that, but obviously it was positive also. So this is kind of a summary of his clinical course. When you look at PCT in blue, the white count in red, and you can see his lactate in green. And you can see in the arrow, that's where we introduced the vancomycin. And we can say something about this physician. We say he should have done this. And yes, he didn't do it again, okay, or we learned our mistake from that when we're taking care of this patient. But if you're in a facility that doesn't have PCT, you're in the same boat, if you think about it. Because that's the beauty of PCT. It helps you with severity of illness, and it looks at change in bacterial load over time. And that's one of the greatest values of PCT use, is knowing what that change is over time and catching your patients before they get worse, before they get into sepsis. So takeaway from that, the clinical pearls is, the diagnosis of pneumonia, you don't have to have a hugely elevated PCT. In fact, a third of the time, you won't have a PCT it'll be 0.5 or less. But that doesn't matter. It's not the value per se. I mean, although that does help you with severity of illness. Even if you had a pneumonia with a PCT of 0.5, because it's fairly focal, it's a very small amount, or perhaps it's from an atypical organism, the next 24 hours, if that PCT is 0.5, what do you know? Went from 0.5 to 0.3, what do I know? Effective therapy. If it went up from 0.5, obviously a cause for concern. So significant elevations of PCT, they can help you evaluate your therapy and help you assess. So this data is from my hospital. We presented this to the FDA in December, and I'd like to share with you some outcomes data. We looked at 2,152 patients. What we did is we took extrapolated data from 4 years. We took a 4-year time frame of patients with PCTs before the use of PCT. Okay, that was 985 patients. We allowed 1 year for education, and then we looked at 4 years worth of data, which was 1,167 patients post-PCT. We've been using PCT. It'll be formally completely adopted 7 years in March. Okay, so we've been using PCT for a while. So if you look at the comparison of our groups, we want to make sure that our study groups are the same. You can see that the mean age was the same, 70 years, which is statistically similar. Male to female, similar. The diagnoses, and this was what we presented to the FDA. We also looked at urinary tract infections. We looked at essentially all of the breakdowns, and they were the same between the two groups. But you can see the difference is the antimicrobial days of therapy in the pre-group was much higher than in the post-group. Okay, and I'm going to talk a little bit about antimicrobial days in just a second. We included all patients with the ID diagnosis that we talked about. We took all age groups. This includes pediatrics. The only patients we excluded were patients who required surgical prophylaxis or who got transferred. Okay, so they wouldn't skew the data. The process in place, as I described, where a pharmacy made sure that we communicated and we worked together as a team with our physicians and all the orders were reviewed. And this is what we were able to find. We actually are able to demonstrate a 42% reduction in antimicrobial days of therapy. And we point out one thing very important. We're talking antimicrobial days of therapy, not daily defined doses. Daily defined doses is not really a true measure. The World Health Organization uses that, but that information can be skewed by the doses of your antibiotics and things like that. This is truly days of therapy down to a quarter of a day. So we had a 42% reduction in antimicrobial days of therapy, which was statistically significant, a 57.6% reduction in mortality. This is not ICU only, this is hospital-wide, okay? A 47.2 reduction in 30-day readmissions. This is one of the things that we initially ran up with. When we stopped therapy sooner, everybody said, well, we're going to have our 30-day readmission rate is going to go up. It went down because remember, you're basing your decision on a change in bacterial load, not a marker that is usually affected by inflammatory responses. We had a 64.6% reduction in Clostridium difficile infections and a 50% reduction in adverse drug events. All of those achieved statistical significance. So better use of antibiotics is the key, duration is the key, but you get that better use at an individual patient level based on that change in bacterial load.